So our next paper is, Does Public Health Insurance Affect How Much People Work? The presenter is Gal Wettstein, and his discussant is Laura Schmitz. And Gal, congratulations on being the first man on the program.
Well, hello, and thank you all for being here, and thank you all for also for to SSA for funding the dissertation fellowship program that funded this work. I guess in talking about health insurance and retirement, the first question to ask is, what does health insurance have to do with retirement at all? And the answer is that because most Americans get their health insurance through their employer, group plan, retirement and health insurance interact in the decision people make. The reason people get their health insurance from an employer often is that for various reasons, like adverse selection or dynamic contracting, group plans are just often better than individual plans on various measures. They're cheaper and more generous. So people who rely on their employer for coverage might, when they consider retiring, think twice, because they might stand to lose that insurance. And this can lead to an oversupply of labor in the sense that people might work beyond the point where what they produce is larger than the cost to themselves of working. The way this paper contributes is by looking at a new source of policy variation, new for this question. Obviously, many people have looked at Part D. The previous literature has looked at all kinds of policies, but there hasn't been much focus on a policy that affects a broad range of near retirees. And so the introduction of Part D here is a good natural experiment for the labor effects of providing people with more generous drug insurance. I'm sure most people here know about Part D, but just to get on the same page, Medicare provides health insurance to all Americans over the age of 65, but until 2006 it didn't cover anything related to prescription drugs, with a few exceptions like inpatient drugs provided in hospitals and things like that. However, the share of health spending that's devoted to drugs has been steadily increasing. It was about 5% in the early 80s. It was over 10% by the eve of Part D's introduction. And so the addition in 2006 of Part D coverage to Medicare for the first time really gave everyone over the age of 65 access to subsidized drug insurance. Now, this was particularly important for people near retirement. As I said, most people get insurance through their employer, and of those who get insurance through their employer, almost everyone has drug coverage. Before Part D, individual drug coverage, however, was very limited. For people over the age of 65, standalone coverage was virtually non-existent. And though Medigap and Medicare Advantage offered some opportunities for drug coverage, those were not very generous, they were very highly priced, and as a result they were very rarely taken up. So for instance, of the Medigap plans that provided coverage, only 3% of those eligible chose those kinds of plans. So typically the situation was that people who had drug insurance from their employer, if they retired, they would lose that drug coverage. What I'm going to do, as a number of other papers have done today so far, is use the health and retirement study, and I'm going to limit the sample to people who were directly affected by the introduction of Medicare Part D, so people near the age of 65 and near the years 2006. And essentially the methodology in the paper is a differences in differences design, where I use eligibility for Part D to see the effects, and eligibility is based on age. You're eligible if you're over 65, and on year if you're observed after 2006. Now, before going on too far, it's worth pointing out that lots of people can't possibly be job locked in this way. If you don't get insurance from your employer, then clearly that provides no bearing on your decision of whether to retire or not. Similarly, people who have retiree health insurance for life are not going to be very affected by job lock. They can retire whenever they want and keep their drug insurance regardless of their age. So what I'm going to do is I'm going to focus on people who have retiree health insurance, but divide them into two groups. The first group is those who have retiree health insurance only until age 65. And this is a pretty common arrangement because at age 65, people become eligible for Medicare. These people could potentially be less job locked after Part D's introduction than they were before because Part D was the first time they would get drug coverage through Medicare. And I'm going to call these people the treatment group. The second group is people who have retiree health insurance for life, and these people, as I said, should not be affected in terms of job lock by Part D's introduction, and I'm going to call them the control group. The advantage of having this additional control group is that they're observed at the same ages in the same years as the treatment group. As you can imagine, people who turned 65 after 2006 are not the same cohort as the people who turned 65 before 2006. So what I use for identification here is so some first results. What I do here is plot the share of people working full-time by age, pre and post Part D. And you can see that the pre and post Part D declines in full-time work were very parallel until age 65, suggesting that the pre-65s are a reasonably good control group for the people who, the pre-2006 group are a good control group for people who turn 65 after 2006. But you can see that after 2006, there's a much sharper decline at age 65 than there was before 2006 in full-time work, suggesting that Part D had some impact. When I do the same thing for the control group, as you might expect and hope, there's no change in the pre and post 2006. So this is a good thing, because when thinking of them as a placebo group, you don't want them to experience any effect. But comparing the treatment and control groups between each other, you can see that, again, the control group looks like it moves quite closely in parallel with the treatment group before age 65, again suggesting that these are reasonably good counterfactuals for what would have happened in the absence of Part D. But again, at age 65, there's a much sharper decline for the treatment group than for the controls. To show that this is robust to including other controls and to test for statistical significance, of course, I estimate some regressions. The main outcomes I'm looking at are full and part-time work. And the key independent variable is an interaction of indicators for being over age 65 after 2006 and being in the treatment group. And then, of course, I also control for all the first and second order interactions of those indicators, as well as year, age, and individual fixed effects, and other demographic and health variables, except for some regressions at the end that I'll show you that don't have health controls. And the hypotheses, just to recap, are, first of all, that Part D will decrease full-time work because it potentially reduces job lock. But the second thing is that it should increase part-time work. And the reason is that most employers don't offer health insurance to part-time workers. So you could be job locked not only with respect to full retirement, but also with respect to your decision of whether to scale back or cut back on your hours. You don't want to lose your insurance because you want to work less hours. Finally, you'd expect a bigger effect among sick individuals because on the one hand, it's much more difficult for them to work potentially, but on the other hand, health insurance is much more valuable, so there's much more scope for job lock in this health impaired group. The results from the regressions are, well, the main results are displayed in this figure. You can see that there was a really big, dramatic decline of 8.4 percentage points in full-time work for the treatment group. But again, this is a very dramatic decline, but there was a large offsetting effect of an increase in part-time work, again, consistent with the mechanism here, offsetting about 70% of the decline in full-time work. And you can see that there's almost no change for the control group, again, consistent with the figures you saw before. So as I said, it's a big effect. The 8.4 percentage point decline is equivalent to about 24% decline in full-time work for the treatment group. But as I mentioned, only 30% of that is people actually retiring completely. Most of it is people moving into part-time work. Also worth noting is that while there was a big effect, it was focused on a pretty moderately sized group. So to begin with, as I mentioned, there's no scope for job lock at all for the 41% of people who have no employer-sponsored insurance, and in work I don't show here, I indeed find that they had no effect. Also no effect for the control group, as you saw, the people who have retiree health insurance for life. So really all of this is just the 40% of people who have retiree health insurance, who have employer-sponsored insurance, but I'm only looking at the ones with retiree health insurance. But again, even within that group, the effects are really focused on people with severe health conditions. So among this relatively aged group with relatively generous insurance, that's a large part of the sample, but it's still just 2/3 of the people I'm looking at, the people who have at least one of these pretty severe chronic conditions. And when splitting this estimation model to include only people with these health conditions or only people who are healthy, you can see that the entire effect is driven by the sick group. So there's a 12 percentage point decline in their full-time work and a 10 percentage point increase in their part-time work, but virtually no effects and certainly nothing significant for the healthy group. So let me conclude maybe a minute ahead of time. The declines around age 65 when provided with public health insurance were really dramatic in full-time work, about 8.4 percentage points or 24%. But those are largely offset by increases in part-time work. And this is consistent with some previous literature on job lock, which has found relatively little on the extensive margin of labor, but a lot more on the intensive margin. And then, of course, this comes with the caveat that about 50% of the population who shouldn't have any effect really doesn't have any effect from Part D. That's consistent with the mechanism I'm talking about. And the effect is really concentrated among the sick, and there was no effect for healthy individuals. Thank you.